Can you see? Can you see?
Yeah.
Thank you. Thank you.
Recording in progress.
Yeah, very good. Okay, you can start your presentation from this slide
Okay.
again. Yeah, thank you.
Thank you. Okay, so like I said, the principle of symmetry is also so much important. And anatomy and topography principles, there's many principles, yeah? So the knowledge about anatomy is so much important. And we can learn about it, we can read about it, but many times the nature will disappoint it, you know, disappointed us. For example, this is my patient who got 2 roots in first upper molar and 5 canals. So many times our knowledge will be not enough. We need to send patients to tomography. And I also recommend to my students many books about endodontists. This is unfortunately books wrote in Polish, but the first one is something like Endo Bible, and I think every country, every university got Endo Bible with basis of endodontics. The second book is about microscopic endodontics in practice, and is dedicated for young students who wants to start working with microscope. The third one is about endo cases, like clinical background of many cases. And the last one is endoprosthetic. We need to know, and I always said to my patient that 50% of success in endo is root canal, but the other 50% is good prosthetic.
My friend, can you hear me? Dr. Nicodem, can you hear me? You're connecting again. Please unmute your.
Okay.
Yeah.
Can you hear me?
Yeah,
And
yeah, it's now okay.
Can you see the screen?
Yeah, it's clear.
It's clear? Okay. So the second one, clinical examination. So much important because patient wouldn't give us an answer and locate the pain. Many times we need to find the reason of his pain. So mainly we do cold tests. It's a good examination, but of course we need to know that we got others pulp vitality test. And my question is cold test always predictable? Doctor, what do you think, Dr. Ali?
Actually, based on the articles and the literature we have, cold test is a good option for tests which has irreversible or reversible pulpitis, but it is not accurate in all situations. For example, if we have pulp canal arbitration or pulp canal calcification,
Yeah,
the
that's
EPIT
right.
test is better than cold test, and the
Yeah,
cold test is not very good
that's
at
right.
all the situations.
Yeah, and that's my point, that the young endodontist should know that cold test isn't really reliable in every situation. Of course, like you said, we can diagnose pulpitis. And this is a example of my patient. The patient was referred to me for root canal, but I do very precise diagnostic. I asked him many questions. What's the pain? And he told me that he got periodic pain, non-spontaneous pain since 2 days. And I also asked the patient from 1 to 10, how big is your pain? And patient said it's 6. And the pain was mainly for cold and when he was biting. So I analyzed
Dr. Nikodem,
yeah,
can I ask you to share your slideshare because
you cannot see.
I see,
Okay,
yeah, it is on your PowerPoint. It's
okay,
not
okay.
on your screen share.
How about now?
Yeah, it is good now. Thank you.
Good. Yeah. So this is my patient I was talking about. Yeah, I uh, analyze X-ray and we can see deep cavity, maybe penetrating to the pulp, but we have to know that the last word and the last diagnosis is when we open the tooth and we see the situation inside. So my diagnosis was reversible pulpitis. I tried to do vitally pulp therapy, and I did, like you can see on the picture, I put MTA, I did indirect pulp capping, and after 1 month, the pain's gone. The vitally test, the cold test was positive, and I introduced patient that maybe in future root canal will be needed. You always need to inform patient when you do vital pulp therapy that we cannot give him 100% sure that root canal wouldn't be needed in future. And this is a very good research about new diagnostic system for pulpitis. It's made by Professor Duncan from ESE and Professor Walters. So I recommend you to read this article because it can help us to decide when can we do vital pulp therapy and when root canal is needed. So now we have a new diagnostic system, and we can say that we have initial, mild, moderate, severe pulpitis. In the old one, we have reversible and irreversible pulpitis. So it changed. And I have a question for you. This patient was referred to me with lower incisor. The crown of this tooth was, darker than others. So the doctors referred this patient for root canal. The patient hasn't got any symptoms. Mm, the CBCT looks like that. And I have a question. Do we have to, is this root canal needed in this situation?
If you ask me if
Yes?
I do the test is we can rely on
The
cold
cold
test
test
or
is negative,
it's negative
unfortunately.
completely because yeah. But I think this needs no any treatment because when you look at the CBCT radiograph, you see no periapical lesion, and if the tooth is
Yes.
completely asymptomatic, if we don't have any pain on percussion or on palpation, we can say that this tooth is completely vital, and there is no need to do any actually root canal treatment for this at least at the present situation.
Yes, of course, of course. When we do all of these steps, medical interview, I asked patient about his history, medical history, and he said that he got trauma in a childhood of this tooth. So it gave us more information about this tooth, and we all know that after trauma, the pulp chamber obliteration is a very common thing. So yeah, like you said, this tooth uh, doesn't need root canal. So precise diagnostic is the basis. Another very important thing in examination is uh, gingival packet probing, especially before retreatment. We need to probe the tooth, around the tooth, every point, because when the probe is going deeper, especially in one point only, deeper, more than 5 millimeters or 10, we know that it is a big possibility that we have vertical root fracture. And this patient was, didn't believe me that this tooth is need to be removed. So I opened the tooth, and what can I see was a white line. And we all know that is vertical root fracture. I take a photograph, showed to my patient, and now he knew that uh, he need to remove this tooth. Root canal treatment wouldn't be successful in this such of case. So examination is basis. The third advice, third tip, working in the microscope. When I was a student and when I graduate my university, I really didn't like endodontics. The reason was that we at the university we didn't work with the microscope. We don't even work with the rubber dam. So endodontics was very stressful, you know. And when something is very stressful, you cannot like it. But when I started working with the microscope, when I got good magnification, illumination, when I see what am I doing, and I started to be an endo passionate. So I recommend you to start working with microscope or loops with illumination. Yeah, is it recording? Yes. Can you hear me?
Yeah, it is
I cannot.
recording and I can completely hear
Yeah.
you.
Yes. Okay.
Very
Perfect.
good.
So I can continue.
Yeah,
Yeah. So
sure.
working in the microscope is, of course, faster, more precise. It's a better ergonomics for us. And when my patient asking me, do I need microscope treatment? Because it's, of course, more expensive. I always, explain them that I need to clean the inside of a tooth, and it's the same like you wanna tidy up your room in the dark without light, without magnification. You can clean your room, but it wouldn't be so precise like in the light. So the same with your tooth. If you wanna clean it very gently, very precise, you need to use microscope. And this is my patient, and this is a reason I'm using microscope. I wouldn't find 6 canals in the lower molar without microscope. It's impossible. And we all know that if we want a successful root canal, we have to find every canal. And this is a good advice for young endodontist, because nowadays we all know that upper first molar in 90%, 95% got 4 canals. And the most difficult to find is mainly MB2 canal. And when I was a young dentist, I thought that when I open the tooth, the openings, root canal openings will looks like that, will be, you know, wide and easy to get. But the realistic is that you need to remove the dentinal shelf and find a canal, MB2 canal, which look like that. It's a white line which you need to shape it and open. So I mainly use Mansber. If you're asking me how to find the MB2 canal, it's good to use Mansber. And why it's so difficult to find? The reason is, look at the photograph. This is a patient, 9-year-old, 25-year-old, and 40. The MV2 canal with, when we get old, it's getting mineralized and obliterate. That's the reason it's so hard to get. The fourth tip is endodontic training. Young endodontists should train a lot, and at the beginnings should get many courses, many lectures. The best one is endodontic compendium. The other training for young dentists is four-handed work with assistant, rubber dam training, CBCT analyze. Those things are the basis of endodontics. And when you get a course, you should train a lot. And this is my endo training four-handed work with assistant, because I want to make my work more ergonomic, more efficient. So you have to train with your assistant. At the endodontist, focus only on the microscope, and good assistant will give the device you need to your hand. Okay, can you see the video? Is everything clear?
Yeah, everything is good, man. Very clear.
Yeah,
Thank
can
you.
you
Thank
see
you
the
for
video?
your presentation. Yeah, completely.
Perfect. Thank you.
Perfect.
I don't have experience with Zoom, so that I'm asking. That's why I'm asking. Thank you. Okay, the
Thank you.
fifth point is training on extracted teeth. I think for young endodontists is the best way to improve endo skills. You need to find your friend or some dental surgeon who will give you a extracted tooth. You can disinfect them and do training. You can, of course, use models. You can put out the fake tooth and put inside the real one, and you can train. There's so many possibilities nowadays to train. You can buy your own acceleration, contra angle, and practice a lot. Yeah, I practice on such a device like what you can see on the right side of the screen, and even the apex locator is working. So nowadays, sky is the limit. We can train in every way at home and improve our endo skills. The sixth advice is to find a good mentor. Find at the beginning of your dental work, find a good dental office where you can when you can have a good endo mentor, endodontist with big experience, who is you know um, who wants to learn you something. Yeah, you should analyze your X-ray photos. You can do medical consultations with other doctors, and you can learn from other mistakes, not only from your mistakes, but from others' mistakes. So we all doctors should help one each other, but we need to, at the beginnings, we need to find a good dental office where we can train a lot. The next advice is treatment planning. We all know that root canal and endodontics is one of the most time-consuming treatment in dentistry. So it can be stressful for us to sit 2 hours with the patient. So at the beginning, I would recommend you to maybe divide the treatment for 2 visits. Plan everything before. See the X-ray. Talk with the assistant. It have to be a good teamwork. And at the beginnings, young endodontist should rate difficult of the case. And here we can see an article which is made by American Association of Endodontists, and they rate cases with low, moderate, and high difficult criteria. And we can see that high difficult criteria is, for example, second and third molar, extreme rotation in position in the arch. But the low difficulty is, for example, anterior, premolar. So those cases for young endodontists at the beginning will be better than starting with high difficulty. So I recommend you to read this article and at the beginning take the low difficulty cases, but when you get high difficulty, maybe direct the patient to the endodontist. And this is my patient, and he was referred to me with a second molar, and I thought it will be easy case. But when I do tomography, CBCT, you can see that the roots of this tooth penetrate into the maxillary sinus. So in compared to American Association, it will be high difficult case. We got second molar, the roots are penetrated into the sinus. So at the beginnings, it's better to direct such a cases to other doctor more with more experience. So I used here bioceramic because I know that the sealing can enter to the sinus. So when it's bioceramic, we don't need to worry. And tooth reconstruction, like I said before, we need to communicate with the patient that successful in endodontics, 50% is endo treatment, but the other 50% is prosthetic. This research is very interesting because it showed that the tooth after root canal is losing even 80% of mechanical strength compared to the vital tooth. So 80% is so much, and we need to direct patient that the tooth after root canal is much more weaker than vital tooth, and the patient need to do prosthetic. We can see that we lost 5% for opening points, 60% when the cavity is big, for example, MOD preparation, 14% when the tooth is not vital. So totally is even 80%. And those are the examples of patient who didn't respect my directions. Yeah, so those patients didn't follow the recommendation, and this teeth was root canaled 2 years ago, and the patient didn't do the prosthetic and visit my dental office to control, and we can see vertical root fracture. Those teeth must be extracted. And I like to take a photograph and show it to the patient that prosthetic is so much important. And the next advice is analyze X-ray. We need to know if our root canal treatment is working. So I always recommend to visit patient after half year, 1 year, and 2 years. We need to check if everything's fine. We can also recording our treatment using a video track in our microscope, and we can see if we can change something, if we can do it more efficient, what can we do better. So follow-up visits and the learning from follow-up visits is also very important. So this is my patient, and I did a follow-up visit that the apical lesion is healing. So follow-up visits is so much interesting for us and very needed. The next advice is that young endodontists should learn from every sources. Nowadays, we got many doctors, many online channels like ours, and the Leaders Show, where we can get knowledge and practical tips. So I recommend you to find this endo knowledge from every source. I like to watch videos from endodontists from all over the world. For example, Dr. Rado, Dr. Nasei, Dr. Rikuchi, and from every doctor from Endo Leaders. And the last one advice is that young endodontists should educate all the time. We need to read clinical study, researches, but we need to know which research is worth to read, because nowadays we got many researchers that the conditions of experiments are not so good. So we need to be very precise in reading such researchers. We need to do our conclusions, and we need to find what works for us. We need to make a good instruction to our assistant, because we need to have good teamwork. And we take a part in many courses, many lectures, but I recommend you to get all of this information and put it in your notebook, because after 1 month, 2 months, after course, after lecture, we can forget many important stuff. So it's better to keep it in one place, and we can read it before the treatment. And this is my reels on Instagram, because many patients ask me, do I need to, is it worth it to save my tooth? And I direct my patient to my Instagram, where they can read why it's worth it to save the tooth. I tell them that it's not only biting function, many other functions. I tell them about consequence of losing teeth, and I show them advantages of saving tooth, compare, for example, to implants. And this is a video, the follow-up video after 1 year. Root canal treatment. And something when the lesion is very huge, and it's good to take a CBCT to have assured that the lesion is healing. And the other very important stuff at the end of my presentation is to have a good glide path, because nowadays the endoshaping, many endoshaping is doing very fast, very aggressive in for example reciprocation mode. But we cannot forget about good glide path, and do it at the beginning manual glide path, because we can feel what we were doing. Like I said, pre-banded the file, and use the watch winding motion. Watch winding motion and pre-banded file is the basis of good root canal. And in most cases, I pre-bend my file like you can see at this photograph or this. This is a files, endo files that I'm using. Mostly is Azure and ProTaper Gold. But this is like I said, reciprocation tools, Reciproc. I also like it, but I cannot recommend it for young endodontists, because this file is very aggressive. So at the beginnings, you should start with a rotation file, in my opinion. Yeah. And this is my protocol for shaping. I'm doing at the beginning scouting using manual files. Then I'm doing preflaring using opener. Then I measure my full length with number 10. I'm mostly using C-Pilot. Then I'm doing a good glide path, and then shaping, but only 2/3 length. I check I measure the working length again because we know that it can change full length shaping, and I'm doing very fast, like kiss and goodbye when we are doing. And at the end, we need to ask if the 25 number is enough for this root. And to know that, I'm doing apical gauging. Maybe you heard about apical aging. After shaping, finish shaping, we use the same number, but we use night-eye manual files on a full length, and we can change, we can check if it's stopped at our length. If it's not, if it's going deeper, we need to shape our canal with bigger size. This is my protocol. Not for every case. This protocol is mainly for simple cases. And this is my hometown, Bielsko-Biała. I recommend you to visit Poland. It is a Central Europe, and my hometown is located in south of Poland. It is a beautiful town surrounded by mountains. So yeah, hope you can visit this town. And the last advices for an endodontist, that it's better to take a photograph in a slope technique. So you put the tubus 15 degrees to left or to right side, because you want to see all the canals. So do not take a X-ray in a direct in a straight direction, but change the position of your tubules when you using positioner 15 degrees to left and to right. And of course, when you start endodontics treatment, for young endodontists, very important stuff, and for every doctor, is patient safety. So I recommend you to not using such a glasses, but better is used to protective glasses. And of course, using luer lock syringes will help you, and your stress will be much more less. This is devices that I'm using for irrigation. I'm using safe syringes with openings located on the lateral side. I'm using endo activator, manual dynamic activation using gutta percha, eddy, passive ultrasonic irrigation, and also endochuck with spreader that you can use with your scaling tip. Yeah, I'm using fluids, standard fluids for my root canal. And this device I also recommended for young endodontists. It's called endo aspirator. You can connect it with the saliva injector, and this is a tip that can make your work easier. So thank you for this lecture. This is a contact to me. You can find me on Instagram. Thank you very much for having me. It was a big pleasure to can present you this lecture.
Thank you, Dr. Boreki. It was very interesting and very insightful. I really enjoyed the cases and the tips that you shared. They are very academic, and I think most of the endodontists around the world need to follow these rules and these tips if they want to do the best practice based on the highest level of evidences, because the main drawback and the main dark point of these days, I think, is the social media. We see many actually cases, we see many different treatment plans, but the hard part is to choose the best option or the best evidence. And I think the tips that you have shared and talked is the best way to find a path in these actually dilemmas. Can you hear my voice? Let me check. Dr. Nicodem, can you hear me? Dr. Nicodem, can you hear me again? Because I cannot hear you and I cannot see you. Okay, no problem. Dr. Nicodem,
Hello. Yeah, I can hear
yeah.
you. I can hear you,
Can you
doctor.
hear? Yeah, I can hear you
Yes,
and I can see you. Very good. Thank you. Thanks for joining again.
thank you. I said that I agree with you in 100%, doctor, because nowadays we got, I call it University of Facebook, and we need
Exactly.
to be careful with many informations that we can read on the internet. So we based on a evidence-based dentistry, yes.
Yeah, exactly. The problem is that we have Instagram-based dentistry these days, and this is
Yes,
the
that's true.
problem that we are facing, especially with our students. I have many students that they ask me, they say that, for example, I saw that video on Instagram, and I think this is the best way to treat this situation. But when you look at the idea and the concept, you see that it is completely wrong because it is just only presented on the social media. And if it is right, I think it is not good to learn such information only from Instagram and from such social media, as long as we have the literature and we have the articles at the journals. Sorry for
Yeah,
my
of
voice.
course.
Yeah.
We got many good endodontic journals. We got many good researchers. So we have to read them and get our own conclusions.
Yeah, exactly. Okay, I want to ask Dr. Parisa if it is possible for her to come with us. And also, I want to ask my question. I have only two questions from your presentation. My first question is about the case that you did the VPT, vital pulse therapy, for the case. It was upper second premolar, I think, and you did the vital pulse therapy based
Yes.
on the article that you mentioned. It was, I think, a Walter classification about the pulpitis. I have read that article, but
Yes.
actually, at least in my country and in many countries, the main drawback of doing vital pulse therapy is that when you do such treatment, you may face pulp canal obliteration, or if the tooth get to, for example, to show different symptoms and you have to start the root canal treatment, you may face some challenges. And it is actually cost benefit to do some treatment, for example, vital pulp therapy for the patient in your country. And what is your idea about the cost benefit and cost effectiveness of vital pulp therapy for the patient? I want to mention an article which was talking about the age of the patient for doing vital pulp therapy. I can't remember the age of your patient, but doing vital pulse therapy for patient older than 40 years old is not reasonable, or it is not cost effective.
Yes,
I want
that's
to ask
true.
you, yeah,
Yes,
please.
like you said, I agree with you. The regenerative potential after 40 years old is not so good, like the younger patient, of course. So we need to know that. And this article, it's only should help us to get a diagnosis, but I think the most important is to see the pulp under the microscope, intraoperative visualization of the pulp condition. This is the most important because we need to, I always ask me, do I need to do pulpotomy or root canal? And in many cases, when I open the tooth, uh, I can see that root canal is needed. Yeah, because I can see the pulp condition. The pulp is necrotic or is so inflamed that vital pulp therapy would fail. Yeah. So intraoperative condition of the pulp is the most important. The research that Professor Walters made, I think it can help us, but the last word is always pulp condition.
Yeah, very good. That is a good concept, and I really like the article which was published by Dr. Walter. And I think in that article it was mentioned when you have severe pulpitis, your success rate will completely
Yes,
drop down.
yes.
But if you have a mild or moderate pulpitis, you may have the
Mm-hmm.
chance of having success when you are doing vital pulp therapy. And it is a very good
Yes.
point that you have mentioned that looking at the situation of the pulp directly by the dental operating microscope is the most important aspect. And what is your idea about the time of the bleeding? What is your criteria for the time of the control of the hemorrhage and bleeding of the vital pulp? Is it 10 minutes or is it 15 minutes or is it 20 minutes? And I want to, if you can
Yeah.
mention any article.
Yeah, very good question. Because when I read researches about that, American Association tells us that it's 10 minutes. Yeah, stop bleeding 10 minutes. But
Exactly.
European Society tells us that it's 5 minutes, and it's confused. It can be confused. Yeah, but you know, for me also the condition of the pulp. When the pulp is stop bleeding, I can check if the pulp is stick to the canal walls. Yeah, if it fits to the canal walls. When you keep it and you can see that the pulp is not so fit to the canal walls, we all know that it's inflamed. We can see the color of the pulp. Yeah.
Exactly.
So the bleeding is also additional, not the last one decision, I think.
Yeah, yeah, because in some concepts and on some textbooks, it was mentioned that the time for controlling the bleeding is the most important aspect. But I have
Mm-hmm.
many cases, at least in my practice. For example, I have spent about 20 minutes to control the bleeding, and after that,
Okay.
I did the vital pulp therapy, and the case was successful because the bleeding was completely controlled.
Wow. Okay.
Yeah, exactly. And I
Mm-hmm.
just want to at least mention my experience, and it seems that
Mm-hmm.
based on the current evidences, that the control of the hemorrhage is not
Mm-hmm.
is not the most important thing. The single
Yeah,
situation of the pulp is more important than I think the
that's
time
that's
for the
a very
controlling.
good evidence that we can read many stuff, but in a realistic treatment, we can,
Exactly.
you know, get confused. So, like you said, it was even 20 minutes, and it was successful. So, very good. Yeah, amazing case.
Yeah, exactly.
Yes.
And my other question is about the case that you have mentioned. It was central mandibular tooth, and you ordered the CVCT for the tooth. The
Mm-hmm.
tooth had pulp canal obliteration, but there was no any sign and symptoms and no periapical lesion. Decided to not to
Mm-hmm.
do any root canal treatment for the patient. I want to ask you about the restoration part of the tooth. For example, the restorative dentist may ask you, I want to have intracanal space in order to have my coronal restoration. If they ask you to prepare some coronal restoration and any any canal space in order to complete the restoration, do you prepare any canal space without doing the complete root canal treatment for the restorative dentist or not? For example, you can use drill in order to have 3 or 4 millimeter space in the tooth without reaching the root canal, and then the restorative dentist can use any post or fiber post in order to complete the treatment. And you haven't done any root canal treatment because you can see at the CBCT there is no need to be concerned. We shouldn't be concerned about reaching the pulp, because there are some space between the pulp and the end of your fiber post or any post in the root canal. I want to ask you about this concept, and if you have any issues like this for the patient for the dentist that referred the case to you.
Yeah, I can see your point, Dr. Ali. And this is a good question because, in this case that I presented, the tooth structure was in very good condition. The tooth, in my opinion, was vital, only was discolored. Yeah. So I wouldn't recommend a patient to do prosthetic on such a tooth. Maybe if the patient would like to change the color of the tooth, I would prefer veneers. But if the tooth is vital, we all know that it got very good strength, and we don't need to do prosthetic. So in this case, the crown was saved. The natural tissue was saved. So I wouldn't recommend the prosthetic. But in other cases, maybe rebuild with the composite is enough when the tooth is vital. Yeah.
Very good. But if the restoration treatment plan for the restoration is complete full crown restoration, did you go for the root canal treatment in such cases, or or in such situation you just wait for the symptoms and then you will try the root canal treatment? What is your idea?
Yeah, in this case, the patient since childhood doesn't have any symptoms, no symptoms. Yeah, so of course prosthetic want me to do root canal. Yeah, because they
Exactly.
don't they don't like to take a risk. But I think I would take a risk and make for example a composite crown on this tooth. And in future, if there will be an apical lesion, we can do root canal without destroying the crown. Yeah. So on this specific tooth, I would recommend a composite crown, and I wouldn't do root canal treatment because it's alive.
Exactly. Assume a situation that you have to do root canal treatment for such trees with pulp canal arbitration. Did you go for endoguide, or you just rely on your dental operating microscope and your skills? What is your treatment plan for such cases that need root canal treatment?
With obliteration that need canal treatment, yes?
Yeah.
Okay. When we have apical lesion.
Yeah, exactly. When we have apical lesion, did you actually use dental operating microscope, or you design a endoguide template?
Yeah, I heard about endoguide template, but I cannot. I haven't chance to use it yet. But when I have such a cases, I'm using CBCT. I'm taking many X-ray pictures even during the treatment. Yeah, I'm making opening points, and if I cannot find the canal, I'm taking another point X-ray picture to see if I'm going in a good direction. Yeah. And
Exactly.
in such a cases, obliterated cases, I'm using manual C-pilot number 6, the pink one. Yeah, because the
Yeah,
canal
exactly.
is so wide that we need to use even the file number 6.
Very good.
What is your solution for such a case,
Because I
doctor?
have the experience of Endo Guide,
Yeah.
and
Mm-hmm.
we have articles that doing such treatment with freehand technique, as you said, your technique is called freehand technique. And when you use
Mm-hmm.
Endo
Mm-hmm.
Guide, you will
Yes.
have the lower chance of misdirection and weakening of the tooth
Yeah.
structure. And I have the experience of
For
having
sure. Yeah.
endoguide, and when you use endoguide, you are going exactly to the point of the entry of the
Yeah.
root canal, and it is very actually safe, and it is not dependent on the skills, and it is not actually
Mm-hmm.
practitioner dependent, and it is very safe and very easy way. You still need to have dental
Mm-hmm.
operating microscope. You still need to have or you need to have order CBCT, but the procedure is much easier.
Mm-hmm.
And
Yes,
at the
for
next week
sure.
we have a conference in Iran, which is
Oh.
International Congress of Iranian Endodontists, and I will share such cases, and we will talk
Mm-hmm.
about the endoguide in the modern endodontics. But it is not online. But if we have the chance to have you in Iran, you can attend us.
Aha.
But unfortunately, we don't have the chance
Okay.
to have you in Iran. But if
Yeah,
I,
thank you for an invitation. Yeah, Endo
yeah,
Guide is, I think Endo Guide in such a cases, obliteration cases, it's a future. It's modern
exactly,
endodontics because we want to save the tissue. So so
yeah,
yeah, I agree
it
with this method. Is very good. It's maybe more expensive for the patient because we need to
exactly
print the yeah,
the most
model.
the most
Yeah.
challenging part is the price of doing such a treatment,
Yes.
especially at least in my
Yeah, yeah.
country. Yeah,
Yeah, that's true.
very good.
But
Okay, I don't have.
it's
Yeah,
worth
yeah,
it. Yeah,
go on.
it's worth it.
Yeah, it's worth it because you save a tooth, and you don't have to be stressful during the treatment, because when you do treatment under dental operating
Yeah,
microscope, especially, you still have
it's so much
stresses. Yeah,
precise. Yeah, much more
yeah,
precise, of course.
exactly.
Yeah.
Okay, I want to ask Dr. Parisa if it is possible for her to open his camera and join us. Dr. Parisa, do you have my voice?
Okay.
Yeah, let's wait for her.
Okay.
Hi, do you have
Hello,
my
Hi,
Dr.
Dr.
voice?
Parisa.
Parisa. Nice to
Yeah,
hear
yeah, we
you.
Yeah.
have
Nice to
you.
meet you.
Nice to meet you, Dr. Borky.
Hello,
I
Dr.
was
Parisa.
listening.
Yeah, we
Hi,
can hear
hi,
you.
Doctor.
Hello, Dr. Parisa.
Hello, Dr. Borky. Hi, Dr. Ali.
Hi,
I'm
thank you.
just
Thanks for joining us.
shaking. So happy to be with you guys.
Yeah, we have your camera, and we have your voice completely clear. Don't worry about
Okay, so
the
good.
camera.
Then let's go.
Thank,
I first wanted to thank Dr. Baraki because of his beautiful slides and presentation. I think he told us very simple the principles of endodontics because everybody, like I mean a general practitioner, needs to know about these concepts. Like, I loved the program that you told us about how we can change and how can we know about different cases, because you told that we have moderate cases, difficult cases, or simple cases. It will help us
Yes.
definitely to know how to um, case select, and case selection is really important. After all of
Yes.
that,
Agree with you,
I
doctor.
love
Thank
I
you.
love the I love the conference and the speech of you that you told us about how to use forehand, because I think like assistant is really important in our business, in our work, because as an
That's true.
endodontist I know I need somebody, as you told us, to use the microsuction, somebody to be next
Yes.
to me to give me the hypocaloric or give us irrigation things. And this is so useful to use four-handed endodontics. And I'm a fan of microscope. So, okay, I really agree with you in viral pulp therapy cases and cases like this. We need we
Mm.
need to look at the pulp under microscope and look at the appearance. You know what I mean?
Yes.
Like the bleeding, everything. What's going on over there? Is our
Yeah. What's going on?
environment isolated or no? It's really dirty. And where are we working? Where are we? Because really, I agree. And I have a lot of successful cases in vital pulp therapy because, I'm an endodontist, and all of us are endodontists. We love files. We love to put the files into the canal and say, yeah,
That's true.
everything's so good. But really, maybe in the future, if we can be um, an endodontist, so we can select our cases. If we need a file, okay, I will use the file. If I don't need the file, I don't want to use the file. And this is, I think, our strength. I really want to focus on this aspect of your speech that you told us, that using microscope under, in some cases will really help us. And as Ali told us, yes, I agree with you that endo guided, I mean something to guide us, like, okay, CBCD, we had this kind of thing that could help us to negotiate canals that are really, really tiny, miny, or obliterated or calcified. Because we have, like, in the place that I work, I have a lot of calcified cases. You know what I say?
Mm.
I have always, when a case comes to my private office, I'm like, what's happening? Why don't I have a
Mm.
canal? And I'm
Mhm.
always thinking, what should I do? Can, like, CBCD help me? You told me that you use the pink C pilot files. Yes, I'm a fan of that kind of files also, because I use 6, 8, 10, 15
Yes.
C pilots a lot in my cases, even in like a central maxillary, I mean, even in a really one rooted tooth, not just only
Yes.
in tooth as a first molar or second molar. Even in a central, it can be a challenge for me. Because of that, I think,
Yeah.
okay, if I have illumination, if I have a microscope, if I have a lot of C pilots, I have a special material so it can, open the canal, especially in obliterated cases. These will help us as an endodontist. And of course, when we want to be, have good follow ups, we need good restorations. And maybe this is something wrong in our specialty. Like in Iran, we just do the root canal, and after that, we refer it for the restoration to other dentists. I mean, restoration specialists or maybe prosthodontists. And we don't know what happens after we end our root canal. And it's really bad, you know what I mean? Because I really want to know what happened to my canal. Like, I used
Yeah.
isolation, I use the rubber dam, I use illumination, I know microscope, and I had a lot of focus on my canal. And then I will refer my patient. And
Yes,
do you
that's true.
agree that that in our success, a good root canal treatment combined with a good restoration will help us? We need both of them. We really need both of them. But we don't know what happens. And if something happens good, like in my country, that both of these two subjects combine to each other, maybe our success will be more better and we will have a good prognosis. I want, when I see my tooth after 4 years, 5 years, 3 years, I want a successful rate. And I want to see that everything is going very good. And but it depends on the treatment, restorative treatment. And as Ali told us, when we have an endo guide, because the restoration will be smaller and tinier, because of that, maybe the person that after me wants to restore it, he or she will be more easily. And then when the challenges are lower, the success
Mhm.
rate will be more higher. I really agree in this concept. I want to thank you. I saw your slides. It was really obvious that you um, worked on it, and you told us completely about all of the challenges that as a dentist and as an endodontist we are going to have in our daily practice. Thanks, Ali, as a moderator and as a really special friend that he is always next to us. And I really hope that in the future, Endo Leaders Show will gonna have a very wide concept and very wide goals. I mean, we want to have, a team as a teamwork, very, very good future. And I hope that we will sit each with each other, eye to eye, next to each other. I hope you a very, very good day. I don't know in Poland what time right now. I think you're in weekend. Yes, tomorrow is weekend in Poland.
I think Dr. Nicodim is disconnected. We have to wait for him to come back. Let me check. Dr. Nicodim, do you have our voice? I think he should connect again. Let's wait for him to
Maybe in
come.
Poland they have difficulties like in Iran. Like
Yeah,
I had a lot of difficulties to connect to
yeah,
this program. Maybe.
maybe. But he will connect again. He had the same experience during the session, and he will come back soon. And we will finish the session. It was very interesting. Let's wait for Dr. Nikodem. Okay, it seems that we have gone the connection with Dr. Nikodem. I want to thank him for his excellent and amazing presentation. And this session is going to be ended. And I want to thank Dr. Parisa for giving us her comments. And it was very informative and insightful for all of us. Thanks for joining us,
Thanks
and
to
thanks.
Dr. Ali.
Thank you. Thanks for joining us. And I'm sure that in the near future we will have a better
A
program.
lot
Or it
of
seems, yeah,
a lot of
it seems that,
programs.
yeah, we will
Can you
have.
hear me? And can you?
Yeah,
Yes.
yeah, we can hear you. I want.
Dear
Sorry for
Dr.
my
Burke, where did
sorry
you
for my
go? You
internet
were
connection
here.
was lost. Dr.
What
What
Parisa,
happened
happened?
to
thank you for
you?
your words. Thank you for
What
your
happened to
words.
you? In
It
Iran,
was
we have a lot of problems with internet, with VPN. And then we were just, wow, where are you? We are
Good.
happy
Yeah,
seems
can
to
you hear me?
be next to you.
Yeah.
yeah,
Yeah,
it's
thank you for
better
your
now.
words. It was a big pleasure to present you this
Exactly.
lecture and to be a part of Endo Leaders.
Thanks, Dr. Nicodem. Okay, I will repeat again my final word. I'm very honored and I'm very delighted that we have the chance of having Dr. Nicodem from Poland here. And I'm very happy and I'm very thankful for his excellent and informative lecture. And we learned a lot from Dr. Nicodem. And we hope to see you again in the near future programs. And
Yes,
I
of
will,
course.
yeah, thank
Hope
you,
to
thank you.
see you soon.
Yeah,
See you soon. Yeah, thank you. And I agree with your point that that you said, Dr. Parisa and Dr. Ali. Thank you and see you next time.
Yeah, we'll see you again, and I will have a big surprise for you, and I will send it in the private message. But it cannot be published
Okay.
public, but I'm sure that it will impress you and it will have a good impact on you. And we will have bigger projects in the ELS in the future. And as you said, ELS can become one of the best platform of teaching and learning endodontics all around the world because the endo leadership consists of the esteemed endodontists from all around the world. And this is the best and the most important aspect of endo leadership. And having such great endodontists like Dr. Nicodem, Dr. Parisov, and all other members, you can do a very good session and we can do very good programs together. Thanks for accepting our invitation, and I'm sure that we will see you again in the near programs. And as Dr. Paris said, we can meet each other face to face, eye to eye, at the next programs. Thanks for accepting our invitation, and I want to end this session. Thanks, Dr. Nicodem, thanks, Dr. Parisa, and all the audiences that have been with us till now. Have a good day and hope and looking forward to meeting you soon in the near programs.
Thank you so much. Have a good
Thank you so
evening.
much.
Have a good evening.
Have
See
a
you.
good evening.
Bye.
See you soon. Bye.
Thank you.
We'll see
Bye-bye.
you soon. Bye.
See you soon.
Bye. Please end this.